Namaskaram everyone. Autoimmune encephalitis is increasingly being recognized as a common cause of encephalopathy in children, and many of us have not have had exposure to this entity during our residency and hence may be clueless to the diagnosis and management of these cases. Hence it is important to go through these guidelines in this video, which are the latest guidelines given by the Indian Academy of Pediatrics on this topic. Also, the pediatricians and intensivists should be aware of this entity as early diagnosis and treatment is associated with better outcomes. So, if we go by definition, it is basically a proven syndrome based on clinical semiology. Now, what is semiology? Semiology simply means the science of signs. So, there is a set of clinical signs, and along with this, antibodies are present in the CSF or blood usually, but some children may not even have detectable antibodies. Several types of antibodies may be present, but anti-NMDA receptor antibodies are the most common type in children. The incidence is poorly reported and may be up to the tune of 2.2 per million children per year. And like most of the other autoimmune diseases, females are affected more commonly in this also. Now, there are various triggering factors. Actually, the triggers cause the release of brain-specific neoantigens and trigger the development of pathogenic antibodies against these antigens. So, the most common trigger is infections. Now, infections can be viral like herpes simplex, varicella zoster, Epstein-Barr, human herpes virus 6, cytomegalovirus, human immunodeficiency virus and adenovirus, rickettsia and mycoplasma. As regards herpes simplex and autoimmune encephalitis, it is said that 30% of cases of HSV encephalitis have anti-NMDA receptor antibodies in the CSF, and these can lead to relapse also in 20% of cases of herpes simplex. The next important trigger is post-vaccination, especially for anti-NMDA receptor antibody autoimmune encephalitis, and the vaccines implicated are influenza, polio, DPT and Japanese B encephalitis. And the last important trigger is paraneoplastic syndromes, usually seen with ovarian teratoma, testicular carcinoma, Hodgkin's disease and neuroblastoma. This trigger is less common in children. In less than 18 years of cases, around 31% have paraneoplastic syndromes, and less than 14 years, 9% have paraneoplastic syndromes. The most common malignancy associated is ovarian teratoma in 94% of cases and extraovarian teratoma in 2% of cases. Besides, 4% cases are associated with small cell carcinoma of lung, testis and breast. Now, the antigens against which these antibodies are found can be located on the cell surface. For example, anti-NMDA receptor antibodies VGKC, LGI1, Casper2, anti-GABA-A, anti-GABA B, anti-glycine, anti-D2, anti-AMPA, anti-mGlu5, anti-neurexin 3 alpha and anti-glutamate receptors. But this type of autoimmune encephalitis is common in children, has lower association with malignancy. It is generally mediated by humoral immune system. It therefore shows a better response in immunotherapy and a favorable outcome as well. There are certain antigens which are located intracellularly like anti-HU, anti-MAR2 and anti-GA, but these are less relevant in pediatric age group, usually exist as paraneoplastic triggers. They are mediated by cytotoxic T cells. They therefore respond poorly to immunomodulatory therapy and are associated with poorer outcomes. Anti-NMDA receptor autoimmune encephalitis is the prototype of autoimmune encephalitis in children, and it is the most common, so we shall be discussing the same over here in detail. It constitutes around 4% of all encephalitis cases in children. The most common cause of seropositive autoimmune encephalitis in children is anti-NMDA receptor autoimmune encephalitis. 40% of all reported cases are below 18 years of age. It may also contribute to recurrence after herpes simplex encephalitis, as we had seen earlier also. It is most commonly post-infective IgG1 and NMDA antibodies bind to NR1 subunits of NMDA receptors, and this leads to inhibition of glutaminergic excitation to inhibitory neurons. And this finally leads, that is, inhibitory neurons are excited even more, and therefore this leads to intense excitotoxicity. The clinical course typically follows a triphasic pattern. First is the prodromal phase, second is the phase of varied neurological manifestations, and finally there is the phase of advanced disease. Now let us have a better understanding. The prodromal stage, seen in 50 to 70% of cases, lasts from days to weeks, is characterized by fever, headache, malaise, gastrointestinal and respiratory symptoms. This may lead into the next phase, that is the phase of varied neurological manifestations. These manifestations can be behavioral changes like irritability, temper tantrums, hyperactivity, violent behavior, insomnia, mutism, seizures, which can be focal generalized status epilepticus or epilepsia partialis continua, and may occur at any stage of the disease. Cognitive deterioration, short-term memory loss, and even central hypoventilation syndrome. Or the symptoms can be in the form of movement disorders like orofacial dyskinesias, stereotypic movements, choreoathetosis, balismus, rigidity, opisthotonus, tremors. Or it can be psychiatric symptoms. There can be psychiatric symptoms like psychosis, delusion, hallucination, and catatonia. Even autonomic dysfunction can be the symptom like tachycardia, hypertension, arrhythmias, and hyperthermia. And certain atypical manifestations like autistic regression, catatonia, neuroleptic malignant syndrome, and gait disorder. So in short, every kind of neurological symptom can be present in patients with autoimmune encephalitis. And this finally leads to the stage of advanced disease, which manifests as stupor, coma, periods of agitation alternating with catatonia, autonomic dysfunction, and respiratory failure. For diagnosis of autoimmune encephalitis, we go for a few investigations. First is the CSF examination, which should be suggestive of CNS inflammation. About 80% cases have abnormal CSF in the form of CSF leukocytosis, normal or mild elevation in proteins, normal glucose, and elevated IgG, that is immunoglobulin G index, oligoclonal bands, or CSF neopterin. On MRI of brain, in anti-NMDA receptor autoimmune encephalitis, we get unilateral or bilateral T2 flare signal hyperintensities involving mesial temporal lobe, hippocampal, cerebellar, and cerebral cortex. Hyperintensities may be seen throughout the brain. Cortical enhancement is there in absence of restricted diffusion. It may even be normal. MRI may be normal in around 50 to 60% of cases. PET scan can highlight involvement of mesial temporal lobes. And there is relative sparing of insular cortex. EEG is abnormal in most patients. The findings are usually non-specific and include extreme or diffuse slowing, epileptiform discharges, and disorganized activity. Rather extreme delta brushes are seen in 30% of anti-NMDA receptor autoimmune encephalitis cases. Detection of pathogenic antibody is the basis for diagnosis of autoimmune encephalitis. If these antibodies are positive, then the diagnosis is definite. We detect the antibodies by cell-based assays with live or fixed eukaryotic cells or IgG-based assays. Test both the serum and CSF. In anti-NMDA receptor autoimmune encephalitis, CSF testing is more sensitive. In protracted disease, delayed diagnosis, and after IVIG or plasma exchange, antibodies may be present only in the CSF but obvious, and it has limited utility for follow-up evaluation. The differential diagnosis of autoimmune encephalitis can be infective encephalitis like herpes simplex and Japanese encephalitis, toxins affecting the CNS, CNS vasculitis, inborn errors of metabolism, neoplasms, primary psychiatric disorder, and even subacute sclerosing panencephalitis. Now a word about the seronegative autoimmune encephalitis. Around 50 to 60% of cases of autoimmune encephalitis show no positive antibodies in the blood or in the serum CSF. Therefore, these cases are referred to as seronegative autoimmune encephalitis, and there are 5 criteria for diagnosis of the same. These include: first, rapid clinical progression of symptoms; second, exclusion of well-defined autoimmune encephalitis syndromes like typical limbic encephalitis; absence of antibodies in CSF and serum; presence of any two of the following signs of inflammation, that is CSF leocytosis, CSF specific oligoclonal bands or elevated CSF immunoglobulin G index, MRI findings suggestive of autoimmune encephalitis, and brain biopsy showing inflammation. And the fifth criteria, exclusion of all the other causes like the differential diagnosis we had discussed previously. Now, how to differentiate between autoimmune and infectious encephalitis? Clinically, autoimmune encephalitis can have varied neurological manifestations in phase 2, like seizures, movement disorders, speech abnormalities, sleep problems, and even behavioral issues. Fever is seen in only around 50% of cases, it is not that prominent. Symptoms of autonomic dysfunction can be there, and rash is usually rare. Whereas in patients with infectious encephalitis, fever, seizures, and altered sensorium definitely usually occur. Most of the cases have fever. Rash may be present in varicella zoster and herpes simplex virus encephalitis. In CSF, we get mild leocytosis in autoimmune encephalitis, but marked leocytosis in patients with infectious encephalitis. On MRI brain is actually recommended in children with suspected autoimmune encephalitis during initial evaluation and to rule out the alternate causes. Also, abnormalities are commonly subtle and may be discordant from dramatic clinical features. See, MRI may be normal in around 50 to 60% of cases, especially early in the course. Basal ganglia are often involved. Lateral temporal lobes and insula are less commonly involved. There can be T2 weighted flare abnormalities throughout the brain in cortical and subcortical areas, including the temporal, frontal, and parietal lobes, hippocampi and amygdalae, cerebellum, thalamus, and basal ganglia. There may be contrast enhancement and abnormal diffusion weighted images. On the other hand, mesial temporal lobe involvement is common in herpes simplex encephalitis. Treatment of autoimmune encephalitis comprises of immunotherapy and plus minus surgical removal of tumor, and infectious encephalitis includes acyclovir for the treatment of HSV encephalitis. Now, the approach to treatment of autoimmune encephalitis is tiered, that is staged. So, the first line of drugs are corticosteroids, IVIG, and plasma exchange. The second line of drugs, they are rituximab and cyclophosphamide. The third line of drugs are bortezomib and tocilizumab. Bortezomib is a protease inhibitor and tocilizumab is an anti-interleukin 6 antibody, and it has been used very commonly in patients with COVID. And these three lines, that is first, second, and third line of drugs, they are used for the treatment of autoimmune encephalitis in the acute phase. Then there are certain drugs which are used for a longer duration, that is for 6 to 12 months, and these are usually in the form of oral steroids, and this is referred to as the maintenance phase of treatment of autoimmune encephalitis. Like most of the other diseases with an immune etiology, there is an acute phase and then maintenance, or the phase of remission, in which we continue to give the immunosuppressive therapy. A significant proportion of patients respond to the first line therapy itself, and they show response within first 1 to 2 weeks of treatment initiation. Prognosis is better with early diagnosis and early initiation of immunotherapy. Second line agents also improve prognosis in cases with poor response to first line therapy, severe disease, and relapsing disease. Therefore, if autoimmune encephalitis is suspected, one must start empirical therapy immediately without waiting for even the antibody results, but of course after excluding alternate causes, because steroids in high dose, they can lead to the flare up of the underlying infectious encephalitis if it is there. So coming on to the drugs per se, corticosteroids are the cornerstone of treatment with broad spectrum anti-inflammatory activity and good penetration across the blood-brain barrier. We give methylprednisolone 30 mg per kg per day, maximum 1 gram per day for 3 to 5 days, followed by sustained oral steroids, that is prednisolone 1 to 2 mg per kg per day, and slow taper over 6 to 12 months. We can use IVIG or plasma exchange as an alternative and occasionally concomitantly with steroids. IVIG is given at a rate of 2 gram per kg over 5 days. Plasma exchange 5 to 7 exchanges of 50 ml per kg every alternate day. Early plasma exchange along with corticosteroids have better outcomes rather than alone. No evidence exists regarding superiority of plasma exchange versus IVIG. Giving IVIG may be easier. Common regimens are methylprednisolone plus minus IVIG or IVIG and or plasma exchange during the acute stage in cases with inadequate response to methylprednisolone alone. Now the second line drugs. Rituximab is a chimeric monoclonal antibody against CD20, which is an antigen present on the B cells, which are the precursors which produce antibodies. The dose is 375 mg per meter square weekly for 4 weeks or 750 mg per meter square, maximum 1 gram, IV twice separated by 2 weeks. It results in B cell depletion and reduced pro-inflammatory CD4 plus and CD8 plus T cells. One must get B cell count after 2 to 4 weeks and 3 to 6 months respectively, and consider redosing if symptoms persist or relapse. Generally, rituximab is well tolerated with few serious adverse events, and the infusion reactions are seen in around 1 to 2% of cases. Cyclophosphamide has a broad cellular immune suppression effect. Dose is monthly IV infusion of 500 to 1000 mg per meter square body surface area for 6 to 9 months. Risks of infertility and secondary malignancies are there, which depend on the total cumulative dose which has been administered to the patient. Concomitant rituximab and cyclophosphamide have been tried without any increase in adverse effect profile. Then the third line drug, when both the first and the second line agents fail, this is in the form of bortezomib protease inhibitor and tocilizumab an anti-interleukin 6 inhibitor. Intrathecal steroids and methotrexate can also be used. Now, the drugs which are used for maintenance are prednisolone for 6 to 12 months or monthly pulses of methylprednisolone or IVIG. Steroid sparing agents like mycophenolate mofetil, methotrexate and azathioprine can as well be used. These are often used individually or in varying combinations. They are associated with a reduced risk of relapse if started after the first event rather than after subsequent ones, and they are reasonably safe. Now, 10 to 25% of patients with anti-NMDA receptor antibodies relapse, and the relapse can be reduced by the use of second line therapies and chronic immunosuppression for a longer duration. Whenever relapse occurs, it is first managed with repeat dosing of first line agents, and if not, then we move on to second line and third line therapies. But immunosuppression should be chronic. Azathioprine MMF or repeat dose of rituximab can be used. Treatment is required in approximately 40 to 60% of cases. If a patient with relapse becomes critically ill and requires ventilation, the strategy to be followed should be lung protective. To induce and maintain sleep, relief, agitation, and emotional balance, one can use benzodiazepines, clonidine, or chloral hydrate, but one must avoid neuroleptics as they are associated with a high risk of neurolept malignant syndrome. One must monitor for autonomic dysfunction, which is quite common in these patients with autoimmune encephalitis. Dystonia, if any, can be treated with benzodiazepines, pacitine, clonidine, or baclofen. And one must maintain strict fluid balance. Predictors of poor outcome are delayed diagnosis and treatment, PICU admission, altered sensorium and dysautonomia, and polysymptomatic presentation. So to summarize, autoimmune encephalitis is immune mediated. It is triggered by infections, post-vaccination phase, and as paraneoplastic syndromes. Anti-NMDA receptor antibodies is the most common type of autoimmune encephalitis in children. It is characteristically described in 3 phases: prodrome, the phase of varied symptoms, and advanced phase. The diagnosis requires antibody detection, CSF inflammation findings, and on MRI we can get T2 beta player abnormalities throughout the cortex and subcortex with relative relative sparing of lateral temporal bones and lobes and insula. The treatment is tiered and has two phases, acute and maintenance phases. The prognosis is good if we do early detection and early initiation of treatment. I think now each one of us has a fair idea of as to what is and how does autoimmune encephalitis present, and as to how to diagnose and to manage it. Thank you so very much for a patient watching, and please do share the knowledge. Thanks a lot.